Welcome, everyone. Good afternoon to this Health Overview and Scrutiny Committee on Wednesday, the 6th of March. We're here at County Hall. Welcome to everyone. I don't think we have any apologies today, so everyone who's on the committee is present. This meeting, as usual, is being broadcast live to the public via YouTube. Will also be available for viewing on website after the meeting. So as usual, the microphones are pretty sensitive. They work as far as when you push the button, the cameras will focus on you and you'll be able to speak. But when you have finished speaking, if you can please turn off the button so that the red light goes out, and that means then that the cameras can focus on the next speaker. Otherwise, I would like to welcome, as usual, our Cabinet Lead Member for Health, Mrs. Louise Richardson. And with that, I think we're ready to go to item 1, which is the minutes of the meeting held on the 17th of January 2024. I'd like to propose that these minutes are taken as read, confirmed and signed. Does everyone agree? Excellent, thank you very much. Question time, item 2, we have not received any questions from the public. Item 3, questions asked by members under Standing Order 7.3 and 7.5. We haven't received any questions from County Council members. Item 4, to advise of any other items which the chairman has decided to take as urgent elsewhere on the agenda. There are no other urgent items. Item 5, declarations of interest in respect of items on the agenda. But you need to.
It's the regular declaration, son and daughter working.
Absolutely, thank you very much, Mrs. Newton. And any other declarations? Anyone with any boiled sweets in their mouths wish to make any declaration?
Thank you, Betty, for that reminder. Yes, my daughter works in the NHS, and I know somebody who works for Healthwatch.
Thank you very much. You can carry on sucking now. Dr. Hills.
I feel like it's probably, given the content of Healthwatch and its relation to dentistry, probably mentioned that I work as a dentist.
Thank you very much. No other declarations. Okay, that's good. Thank you very much. In that case, we go on to item 6, which is the declarations party whip in accordance with Overview and Scrutiny Procedure Rule 16. Are there any declarations? Looking around the room, there are no declarations. So item 7, presentation of petitions on Standing Orders 35. We have lots of standing orders, don't we? I have not received any petitions. So in which case we go on to the meat of the meeting. So we start with item 8, which is the LLR vaccination and enumeration program. This item is going to be presented by Mike Sandys, who's obviously our Director of Public Health here at County Hall, and also welcome Kay Darby, who's Chief Nursing Officer for the Integrated Care Board. So welcome to both of you. As usual with this meeting, we take all papers and presentations as read, and thank you very much for submitting the presentation that came through. We've had a chance to read that, and everyone will have prepared questions based on the information that's come through. However, if there's anything over the next sort of 30 seconds or a minute or a couple of minutes that you want to actually pull out of that presentation and just give us any highlights that you wish to draw attention to, by all means, please do. And then we'll go into the discussion and any questions. So over to Kay and Mike.
Shall I start? I mean, there's quite a lot of moving parts in the report, so apologies for the amount of data. I suppose it's the main parts to it. It does pick up on the original concern or interest from the committee in terms of HPV vaccination, but we broadened that out to include a variety of information about vaccination immunisation data. And I'll hand over to Kay, because I think the main part is obviously a bit of a time of transition, really, in terms of responsibility for VACNIM from NHS England to the local ICB. And then I guess there's the public health bit. So in public health terms, I don't have the responsibility for VACNIM, that's Kay. But clearly, from my point of view, working to improve vaccine coverage, particularly in our populations, such as Gypsy Roma and Traveller population, which tend to have the lower coverage, is an important piece of work for me. So I was working in conjunction with Kay and colleagues, with you being the lead or the forthcoming lead for doing the do.
Yeah, so I think the context of some of the slides, as Mike's already said, is that Vaccinims are currently commissioned by NHS England, so they're not commissioned by the ICB, so contracts are awarded from NHSE to providers, and largely our childhood programme is through primary care and through our school age immunisations service in LPT. So we're in a transition year because the delegation of IMS and VAX will be coming to us from 25-26, so we're kind of increasingly moving over from kind of regional sort of control and oversight of contracts to the ICB. So we've got a year in terms of shadow form, and I think, and to work up what we think the benefits realisation is of those contracts being devolved to systems. So off the top of my head, in terms of everything comes down centrally at the moment, so we have no leverage in terms of contracts or performance management. That all sits with NHS England. So what we are anticipating moving forward is in line with the national vaccination strategy. We're hoping to develop more kind of influence as a system and more contractual levers and more kind of deliver more innovative solutions than what's been kind of tried and tested before. So I think the relationship through COVID and beyond in relation to working with local authority public health colleagues will be sharpening that focus going forward to look at what really works for kind of some of our distinct communities rather than a national kind of blanket approach.
Okay, thank you very much. Before I open for questions, can I just come back on one of the points that you actually raised, which actually is obviously you've highlighted the potential for greater localization and creativity on actually reaching particularly harder group communities that we know within Leicestershire in particular, but obviously you're looking at the city and Rutland as well. You've been thinking about that obviously in advance, I suspect, because you know through COVID that was probably pretty obvious that we had issues in certain areas. What sort of things have you got in mind? Have you already started to think about what you probably want to commission to hit those areas?
Yeah, I think the national vaccine strategy is very much building on the successes of COVID. And I think as a system, we are recognised regionally for having quite a robust approach for managing inequality. So while it's not always successful, it's not always been through the lack of effort, if that makes sense. So we're quite fortunate that at the moment, the infrastructure we've developed through COVID is trying to make sure we've got system capacity so that if GPs can't run vaccination clinics for children because they don't have capacity, that we have a system resource that we can help with. So we can either, put vaccinators into primary care, we can help them with targeting populations, booking appointments, reminding people of appointments, as well as also then being able to offer a mobile facility. So the mobile facility can park at a GP practice car park, it can actually go more specifically into communities or to kind of shopping centres. So recently we did an MMR vaccination in the city through sort of Primark from one of the shopping centres, and actually got 31 children and unvaccinated children vaccinated, which was quite significant in like the outbreak in Leicester. And those people will have had multiple opportunities previously to access a vaccine. So these are people who would not probably ordinarily have come forward. So the infrastructure is there in terms of a mobile facility, which we're hoping to expand to cover not just vaccinations, but other kind of health prevention activities. So we've sort of future-proof the vehicles that we currently commission through adapted ambulances. So we now got a private examination space on those, so we can try to reach out not beyond vaccination, but to other kind of areas around screening and other areas of inequality, because it's largely the same populations that we're all kind of chasing.
I'm going to
Can I just add to that? The other bit I was going to add in was not so much about commissioned activity, but by devolving it down to ICB, it should make it more localised in terms of the join up with council colleagues. Doesn't matter if it's me, the rest of the council, or district colleagues. What do we know works in terms of increasing up vaccine uptake? Yeah, mobile coverage is one, but rocking up in a van unannounced, it's never going to work. So that kind of engagement, whether it's boots on the ground, working through, say, local area coordinators, or a number of other council services, just to engage with the community in advance to dispel some of the things around vaccine myths, to make certain that the van is coming, then that's the real opportunity for join up, which is less about paying for it and more just about good joint working.
Thank you very much for that. Okay, I've got Betty followed by Dan, so Betty followed by Dan.
It's just that when you're out on the street talking to your residents, there's a number of residents who are really very reluctant to actually get themselves, in terms of flu, etc., and their children vaccinated. I just wonder what more can be done, whether you do it through schools or what, to encourage parents to come forward to ensure that their children and indeed themselves get the right level of vaccinations. Thank you, Chair.
We have a continuous kind of cycle of interventions, as Mike's outlined. So some of the more recent interventions are we do run webinars. So when we've had, and they tend to be around specific outbreaks, but we do need to kind of start to do this work on a more global level around the importance of vaccination. But you probably will have seen there's quite a lot of media coverage at the moment, not just about MMR, but vaccinations generally, because they've dropped off since COVID. So people have got a bit kind of vaccine weary. So we do a number of initiatives. So we have webinars which are really well attended. So when we've had a measles case in a school, I think there was nearly 100 parents attended a webinar, and then, as Mike said, the van rocked up at that school the day after to kind of do the, you know, you've had the opportunity to speak to some experts in it, make an informed decision, and then take up a convenient offer within the next few days. So we do that. We also put some contracts out to local voluntary sector organisations to do some of the community engagement for us, and we are trying to work through the headmaster's route as well, in terms of kind of the importance of the message through schools, but also importantly with our school age immunisations provider, in terms of trying to add more flexibility into kind of immunisations schedules, and then kind of putting additional kind of in reach into schools on. So I think they're the things we want to build on going forward. Because at the moment, if we have a conversation about a school age contract, there has to be 3 of us in the room, because I'm there trying to bend a contract one way, but the contract holder's NHSE, so we're kind of working as a 3-partite at the moment, but that responsibility will transfer to us from next year, so we can start to work more closely with LPT about what we want the service to look like going forward, because one size doesn't fit all.
Got a good relationship with my chemist locally, and he does a lot of vaccinations, and people seem to be more comfortable going into the chemist than the GPs. And I was just wondering whether or not we could encourage more chemists to do that type of work. Thank you.
Yeah, I can respond to that one. At the moment, and it is a key part of the National Vaccination Strategy, which was built in consultation. So myself and my colleagues were part of discussion groups nationally around what needs to look different going forward. So one of the things we've fed back that does need to look differently going forward is community pharmacies being able to offer a wider range of vaccines, because actually they can't at the moment. So they can only give COVID and flu and I think travel vaccines. They can't give the full spectrum of the full age range of vaccines, such as, you know, your shingles and your other childhood vaccines. And that is a key pillar in the strategy, but for that to happen, there has to be some national levers that change around contracting, around governance arrangements, but at least it's in the strategy. So it is something that will be developed by NHS England kind of over the coming years.
Thank you. Dan.
Thank you, Mr. Chairman. I'm wondering what the anti-vaxxers and their campaign that you see from time to time, and sadly, there is a member of Parliament in Leicestershire who is very much at the forefront of some of that propaganda. But I just get the feeling you're reacting and you're not proactive. You've got to think there's something out there that's causing mayhem and disrupting, because when you look at the figures of the response of where we're going. Now, I know we were all gifted with the vaccine, COVID, and, you know, the queues were forever, because we all felt it was so perilous we'd lose our lives. But there is so a lot of propaganda out there by people who are playing a nasty, nasty game. They're putting people at risk through their own weird views or how they're presenting it. I just think you've got to really build a programme where you are totally proactive. You've got to talk to people. The news from your side is this disease or this illness can cause You've got to really show people and explain, because people say measles are nothing to it, but clearly there is parts of this area very severely affected by lack of interest, and then there will be illnesses. Because people aren't vaccinated, there'll be a spread of it, and it goes on. But I'm just concerned. I like the way you presented, but it isn't. I just don't feel you're thinking it ahead of the game. You've got problems. These anti-vaxxers will not go away, and they'll push their luck and their trade as far as they can within the realms of the law. And I think because of that, you've got to really be very proactive and trying to signpost in dramatic ways. This is the right way, the healthy way, and these diseases could be perilous to certain people. I don't know. I don't have that knowledge and skills, but I'm pretty certain it could be. So good start, but I think you've got to really get the big guns out now, because you cannot allow smaller levels to sort of be the average. We want higher batting levels, and in particular people who could be very vulnerable are ignoring it because they're probably susceptible to some of this stuff they read. Anyway, thank you, Mr. Chairman.
So, Mr. Christian, you had your hand up very briefly. If you want to come in at that point, and then we'll pass over to Mike.
Yeah, I just want to say, as it's obviously a public meeting, that, vaccines are there for a reason. They're protecting people from some very nasty diseases. And I, for one, and a few around the table, I expect, did have measles years ago. And I can tell you it's not a pleasant thing at all. So I would ask parents, if they are unsure, please discuss things with your GP or with another professional, because it's about protecting your children. Thank you.
Absolutely. I mean, I have to say, I absolutely take that point about the protection. I mean, anyone who's come across anyone who's been affected by things like measles, MMR is just an extraordinary vaccine to actually stop that happening. It's just amazing. And your point, Dan, I have to say, we'll name who it is, Andrew Bridgen, is just, it's awful reading, particularly some of his stories from his wife over the last weekend about, sort of feeling almost of being taken over by a cult. Of the sort of anti-vaccine brigade, and they're not a large group, but they are unfortunately very, very vocal, and trying to make sure that we have campaigns that are louder than they are, I think is very, very important for all the right reasons. Over to Mike.
Yeah, thanks. It's an interesting one, isn't it? I mean, the starting point, I suppose, for me was looking at. I would say, if you look at the figures for the childhood vaccinums in the pack, there was a bit of me is like, don't forget, the vast majority of parents in the county do get their children vaccinated. So you're looking at kind of 95%, this kind of threshold target, the herd immunity, 95%. We are pretty close to that all the way through the kind of childhood vaccinums at a year and 2 years, and then at 5 years as well. So there is an element of to use an old phrase of Mrs. Thatcher's, not giving oxygen to people, and overblowing the sense that no one's getting vaccinated. They're clearly not. There are many parts of the country which would, the DSPH would give their right arm to have the vaccination coverage that we've got in Leicestershire. So there is a sort of public thanks to parents who do the right thing. Obviously less so in some of the other vaccinations, COVID and flu. And there are many reasons for that. One, there is that sense of complacency. Measles is a classic. I think some of the things is because it's a generation that's not really been exposed to measles. Learning the hard way that actually it is a nasty disease. So, there was always that teachable moment, as the phrase goes, as people wake up to understand that things which were less prevalent are coming back into view. There is then the kind of anti-vaccination stuff, and we talked about some of the kind of more obvious ones, but equally there is sort of maybe some suspicions and frankly myths in parts of the population. So the obvious one for me is based on the Birmingham experience of measles within the Somali community. It's kind of rehashed that autism link, which was then disproved, and Professor Wakefield obviously got struck off on the back of that discredited research. So I think there are a number of things around vaccine weariness, complacency, propaganda, if you like, as well. In terms of what we do about it, I mean, you know, Kay might want to come in. We talked about that program of work, and at the risk of doing myself out of a job, I think this is why talking about the links in with our local services and the local community is key, because there is a limit to which people, particularly nowadays, and you're perceived as being an expert. We've all had a buff of experts. You know, God knows I've done enough radio interviews over the last few years, and great, but it probably has a limited effect. The real way to change behaviour is actually working alongside people in the community. So I think that's where using our community champions and all the people that we've got working at the kind of direct point of contact is the way to do it. So, you know, I think that's the one we'd want to try and pursue, because your most persuasive person is probably your next door neighbour or your family and your friends.
Right, Kay, do you want to come in on? Thank you. Mr. Charlesworth.
Yeah, just to reinforce the point Mike's just made about the hard to reach communities, it's got to come from within. It's no use me sitting in a room and having a translator and a parent there. That ain't going to work. The person who's doing the translating needs to be the one putting the message across. And you're right, from within the community, and I don't know whether it's religion, cultural, or suspicion of the state, the wider state that drives these issues. But I think we know what they are, and we need people, community leaders, religious leaders, to talk to people and get it in the home, and invariably get the mother involved. Father sometimes can be a hindrance in these things, but the woman drives these things in the home, and that's where the message has got to land.
Okay, thank you very much. Brenda.
Thank you very much. And it's first of all, it's an admission, and I don't mind. I'm old enough to take it on the chin. When I first had this paperwork through, I had to Google what HPV was. And I've got to the age I am and my grandchildren not understanding what this is. So I've got the Google back up that, and it says hardly anything except genital warts. Well, if I read that as a parent, I'd say, well, there's no chance of my children having that. I'm not going to bother with an HPV vax. So where should I have known this information from? Where should I have known about HPV?
I just say schools in particular, just ahead of the vaccination program. I mean, my son goes to a boys' school, but actually they were absolutely educated as why HPV was important for them as boys. So actually, schools, I have to say, are doing an extraordinarily good piece of work, particularly just ahead of the vaccination programs kicking in.
Yep. Yeah. Not much to add to that one. I mean, I was working in Derby at the time we introduced the HPV vaccination, and Derby then was one of the kind of first wave pilots, which then got rolled out across the rest of the region and the country. I think we did do quite a lot of work with schools and still do. And you're right, it's not just genital warts. The starting point for this was cervical cancer, given the transmission of HPV and cervical cancer. And yes, we all like to pretend that our children will never look at anybody in anything other than a platonic way, but it doesn't happen, whether you like it or not.
Thank you, Chair. You see, I the cervical cancer, when you said that, then yes, so I knew that was vaccinated, but I didn't know it was HPV. I obviously it wasn't offered to my children when they were at school. So, and the other thing is, I'm a member. A lot of people are of PPG, of our local doctors, and I wondered whether I was interested in the video that's being done. I've read it somewhere at school with a GP and two students from Beecham College on the 11th of March. So that's going to happen, is it? Is the 11th of March coming up? 11th of March. Or is it page 20? I've just been... Yeah. All right. Yeah, I was reading it. Can that be forwarded to all GPs? Because we all have televisions up in the thing now, and we can probably have that played there.
Yeah, what we tend to do when we make any webinars or any materials, we tend to share them the translation on them as well, so they go onto YouTube. But I'll take it back in terms of I'm not familiar with the detail of where we're intending to share it, but I'll pick it up with the team.
Thank you. And the other thing is that you've got summary of activities at page 25, and one was school alerts. Well, I'm also a governor, and I have lots of things like don't forget to book your child's dinner before a certain time, and somebody's lost a next coat, etc. But I've never had an alert on there, because I get the copies that go all to the parents saying that, you know, immunisations or vaccines coming up, you know, anything that could prompt action from parents or information on this sort of thing. And I wondered whether there's missing a trick there, because obviously schools can do this blanket texting for all their pupils. Thank you.
Yeah, that's an interesting one. I mean, that's particularly around measles. So the alerts and messaging is more where if there's been a measles case in a school, obviously much more of an issue for a city school at the moment, city schools at the moment rather in county. That's where you get your warn and inform letters, which essentially is your child may have come into contact with somebody who's got measles. So they are going out. We've got since October probably, you know, less than a handful of cases of measles in the county. So the parents that have been, you know, that potentially at risk, their children are potentially at risk, will have got those letters. More generally, I know I signed off a letter that went to all head teachers around the more general kind of vaccination messaging. And again, I'm not quite certain how they've then shared that information with their parents, whether some of them have done it via letters, whether some of them have done it by text alerts. I'm not quite certain.
And just one more thing, if I may, Chair. Adults obviously can get the virus, and it's bad for those as well, but they will pass it on potentially to the younger generation. So I know we're concentrating here on the children, but what's the uptake like on adults for the measles? Yeah,
I'll say that one. It's an interesting one because we've obviously measles vaccination applies to NHS staff as well in terms of protecting them from being in contact with positive cases and also being transmitters of infection because of, you know, encountering a high volume of vulnerable people daily, aren't they? So our occupational health advice is if you're of my demographic, you kind of, whether you're vaccinated or not, you're assumed to have a level of immunity because we will have been exposed to it as children, because mainstream, it was available in the 60s, but not commonly available until the early 80s. So in terms of targeted approach, it's not necessarily been the target because most of the older population are assumed to have immunity. However, the comms has gone out to all GPs and to the public that if you don't think you're vaccinated or you've not had both doses, anyone can get a dose of MMR for free. And in fact, if you find out subsequently you had 2 doses, you've had a third, it will do no harm anyway. So the comms message to adults is, if you're not sure, obtain a vaccination. And so that's the work that UCSA are doing, the UK HSA, with families. So obviously if you've got children in a family that are positive, they'll be screening all of the adults and other members of the family as well, in terms of whether they're confident that they've got protection from measles.
And if I can just to add to that, I think that's really important because of course there is a certain age, you don't get your vaccinations when you're on the day you're born. So there is something where vaccination isn't so much, well, I don't need a measles jab, I'm okay. But you should, because in doing that, you're then protecting ones who are too young to receive their MMR yet. So, there is not forgetting vaccination as it's a group thing, not just an individual thing,
Taking those 2 points, actually, Cam, Mike's point in relation to Brenda's question. Can I ask, because I know that this was obviously quite an issue within the COVID vaccination programme of health service staff not taking up the COVID jab, and the point about trying to protect the patients, etc. And taking Mike's point about obviously MMR in particular can't be given to children who are under the 12 months. There was a particular issue with midwifery staff not being particularly good at persuading. In fact, I had one friend who was pregnant during COVID, and her midwife actually convinced her not to have a vaccination because she claimed it was dangerous, which was clearly inaccurate information and potentially quite dangerous. And my concern would be whether we actually are getting consistent messaging through, particularly to our NHS staff in those areas that we know are particularly risky, such as midwifery.
I think the COVID issue is quite specific to COVID. I think that's fair to say. Mike agrees, but that was quite a specific issue in relation to COVID. What we have been doing, and we saw the measles outbreak in Leicester come in because we know it was a rising national issue, and we never got problems of low uptake in some particular areas. So as Mike said, we do actually, if you look at our stats, even in the city, we tend to perform largely above national average, don't we, for the city? But within that, there are kind of pockets of very low uptake. So since early summer, kind of June, July last year, we've had a measles elimination plan in place. And so our occupational health provider, which is through UHL, has been taking that risk-based approach. So they started with staff who are working in high-risk areas and sieving through their records. Does that make sense? So anybody new to the NHS now will get a full occupational health screening. We have people which we call have got grandparent rights because they've been working for the health service probably 30, 35 years plus, and those people may not have records to the standard that we would keep if you were entering the health service now. So the occupational health consultant at UHL has took a risk-based approach and has been screening, staffing the higher risk specialties first, working his way through, including primary care, and has now set up a system so that everyone is notified and they can refer themselves through either to obtain a vaccination or to get serology to see whether they do have immunity. So that's kind of an ongoing piece of work, but it is quite a large piece of work given the scale of the staff and the fact that record keeping back in the 80s and 90s was not as it is today even.
Okay, it's good to hear that we're focusing on those who are sort of coming into contact, obviously, with those who patients, etc., who haven't been there yet. Trevor.
Thank you, Chairman. I'm delighted by the level of sophistication that you have outlined just there. I think we've got totally blasé. You know, we can walk through walls in UK now in terms of measles. What's that? We don't have any measles, do we? Why should we get the jab for measles? And I think, you know, that does actually tell us that there are pockets, probably immigrant population. Yeah, okay, that haven't been in their own area as fortunate as we, as natives, if you like, have been. And so, yeah, that's really good that can happen. COVID, as you said, was a unique thing. We didn't know, actually. We knew it would kill, but we didn't know just how effective the vaccine was going to be. And so that was a learning process. And that's a different level of learning that we've now got. Right, park those two for a sec. Now, my question revolves around something that we said about education. And I wonder just, and I don't know whether our education department is going to like me for this or not, but I wonder whether we do monitor exactly what we teach in health education in that particular curriculum area in the school, bearing in mind that we've got academies and they're not particularly responsible to us for their health content. They might be responsible to something like an Ofsted review, but those are few and far between. But what I'm getting at is, and Mike said, we do circulate head teachers and we do tell them that, and my colleague here said, but actually I don't tend to get much back except from order your meal by this weekend or whatever it is. And I'm just wondering if there is a disconnect where we might well be able to look at or ask that be looked at, or that what is actually taught curriculum wise can be looked at. I float that because it's an important area. That said, Councillor Charles has got the point. It's actually adults that influence here. But I still think that we also need the double whammy of getting this across, to get it to the children, the adults, as well as the adults. Yeah, a couple of points from me for my education department. going back. I thought that schools had been freed from the dead hand of bureaucracy that was the council.
Okay.
That's what we're told. Anyway, glossing over that bit. From a public health point of view, there is obviously a couple of programs which we do. There's the Healthy Schools program, which we run in schools. I would have to check. I know obviously it focuses on smoking, drugs, etc. We'd have to check if how much of the work of the Healthy Schools program picks up on infectious disease and vaccine awareness. So we'll check on that. That's a good point. Then you'll know we've gone through the remodelling of what was the school nursing service into a more community-focused teen health service. Again, working directly with kids. And again, I'd have to check how much of their work is around impressing upon children, either directly or through schools and teachers, around the benefits of vaccination. So there are a couple of we're responsible for those. I do need to check on them. What there might be within curriculums around the kind of PSE agenda or whatever it's called, I must admit, I'm not exactly certain. I suspect not an awful lot, because it's PSE, it's not necessarily health as such, but I'll certainly check on how much of what we do picks up on infectious disease protection.
Thank you very much. Betty.
Mine's just a very quick one in the sense of the public health programme and how proactive surgeries are. I mean, I know my surgery in particular started to send out texts and things with information contained in them, and I find that very, very useful. I don't know how common that is, but it has been very useful for me. Just when the phone pings and I see it's a message from the health and telling me X, Y, and Z, and I just wonder if it's common or whether it's something we should be promoting, but they are helpful. Thank you.
Yeah, we do. I suppose it's the old, we can't make everybody do it, but what we do is we have a serious engagement through primary care. So certainly in relation to measles, we kind of wrote the script for them to say, but actually some surgery is very fast off the mark and sent text out before we standardise the message. But so we do. So our role is also supporting primary care to offer a consistent offer, if that makes sense. So if they're struggling with capacity, then that's why we try to have the conversation about supporting with capacity or supporting them with the processes. But yes, particularly on the MMR one, that was a kind of an ICB script and request to say, can you send this out to all of your patient groups, that either a positive one to say you might be aware measles are circulating, but you have had 2 doses, there's nothing to be concerned about, or we don't have a record that you have 2 doses, so can you kind of come forward? Because often, again, records are sparse for people of certain generations in primary care before we digitalised, aren't they? But yeah, we do support with that activity.
Thanks a lot, Mrs. Richardson.
Yes, I just wanted to point out for adults, I've noticed that there are a few countries now that are actually asking for proof of measles vaccination. So it might actually encourage some adults to come forward. I'm having mine on Friday.
Well done. You can send us the photographs. You can tweet your photographs of the vaccination. It'll be like old school days of back in COVID when everyone was getting their vaccinations photographed. Okay, look, Brenda.
Thank you, and I've forgotten what I was going to say, but I haven't. The second part of what I'm going to say, I can remember. We've had a really good discussion on it, but it still stands that in county we're doing well, and whatever we are doing is working well. But we shouldn't be complacent, which obviously you're not, because we have in the middle of the donut, we have got the city, and a lot of the residents obviously work in the county and so on and so forth. So it is something that we have to keep an eye on. But thank you very much. Oh, I was going to say it's taught at senior school GCSE level immunisation and vaccination.
I think you're right, PSE. Despite Mike's reticence, I think they probably school related, but they are pretty good at covering a lot of stuff that I think probably would be surprised that they are covering. So it's quite useful.
Point, Chair. It's just that from Brenda speaking, I wondered whether or not some of these issues would be relevant for our joint health scrutiny meeting with the city. It's just a thought.
I have a feeling if you come to the agenda at the end, I've got a feeling that we actually have this as an item to come back at some point to the next meeting, I think. Mike.
Is that on measles in particular? I know we're jumping ahead of the agenda, because if it was, I think it would be worthwhile. I mean, just on measles, we did put some stuff in there. I mean, clearly the focus is on the city, driven by the low vaccination coverage. And if you looked at the East Midlands kind of picture, it's a city focus. There's no getting away from that. I think the last 4 or 5 weeks has probably been 25, 30 confirmed cases and as many probables where there would be a strong suspicion. As I said, we have had cases, and I think this comes down to vaccination coverage. We will get cases. We have had cases. We might even get a small outbreak, but I would like to think that the coverage that we've got would stop it being a kind of population-wide kind of outbreak. So, you know, best form of defensive attack. So the more people we can get vaccinated before we get into those kind of bits, then the better. But clearly the issues around working with our underserved populations, those that don't come forward, they're going to be different in the city than the county, but still the consistent bit, and the LLR footprint would make that a good one to look at.
Thank you very much. And yeah, we can confirm it's an item on the next meeting. So it is something I know City are obviously very concerned about. Look, thank you very much, Kay. Thank you very much, Mike. As Brenda and others have said, it was a well-discussed item, I think, from all the right points. So thank you very much. Very, very helpful. Right. So with that, we're going to move on to item 9, which is Health Watch, Leicester and Leicestershire. I think Gemma, who was going to join us, is ill. Oh, actually, can I ask that you actually go around the front, because that way we all get. Otherwise you're lost to us all. So that's brilliant. Thank you very much. So Sarah, I think Sarah Carter, who's community business partner here at County Hall, and also I didn't catch your second name. Is that Hardip? Sure. Thank you very much. So you're here from Health Watch in replacing Gemma. That's right. If you can briefly introduce yourself and say what you do at Health Watch, that'd be fantastic.
Oh, hi, good afternoon, everyone. Gemma's not very well today, so I've stepped in. And my name's Hardeep Chauhan, and I'm Head of Operation Services at Voluntary Action Leicester and Leicestershire. So, as you know, that Health Watch is managed by us with a contract provider, which is why I've stepped in. So I hope that's okay.
Okay. So any questions directly for Health Watch, you'll be able to filter back to Health Watch, or are you happy to actually answer on behalf of Health Watch?
I'll try and answer if I can, but if not, I will direct them through to Health Watch and come back to you. What I have done is I have the paperwork that was submitted, so I've managed to get some time to look at it.
Okay, right. Well, we'll see how this goes in that case. And Sarah, you're more than happy to actually speak for yourself, aren't you? Excellent. Okay, look, thank you very much. So as always with these papers, we've taken them as read because we have gone through them all and read everything. So there'll be a fair selection, I'm sure, of points that people want to discuss and ask questions about. Now, obviously, it's probably going to be a bit unfair to say, are there any points that you wish to pull out from the report because you've read it in the same way that we have? But if there is anything in particular, 30 seconds worth of highlight that you think from a Health Watch perspective or from an Leicestershire County Council, I was going to say LRR perspective, but an LCC perspective, by all means, please do. And then we'll go straight into questions and any debate.
Yes, of course. So, yes, I have just pretty much done what you guys have done, read the papers just before coming to the meeting, actually, just so that I was prepared. Just to say, I guess the key point is that Health Watch has been with Voluntary Action Leicestershire previously, and now we've had this contract coming up to a year now. So what Gemma provided in the presentation is kind of a national picture and then what that means locally. But just what in the year that we've had the contract, we've seen what we wanted as a provider was almost an alignment to some of the Health Watch priorities and plans that is local and locally based, and echoing some of the things from the presentation earlier, also links in with the voluntary community social enterprise sector. So it's more of a collaborative approach between health and social care services and the voluntary community social enterprise sector and the communities that Health Watch will be working with. So that's just the key thing that I wanted to flag from the presentation. And then I think the rest of it was pretty straightforward. So that's all. Thank you.
Sarah, at all or not?
No, just to say echoing the thoughts there, and I'm happy to take questions on sort of county council side of detail.
Thank you very much. Okay, so I'm going to open to questions straight away in that case. And I can see Dan first, followed by Betty, followed by Brenda. So we'll start with those three to start off with, and then we'll come back with any particular follow-on points. Dan.
Thank you, Mr. Chairman. Good afternoon and welcome. I am concerned, I have read it with care to try to understand what you actually do and how you sort of represent the public, because in some ways it slightly conflicts with us. We are here scrutinising the health services, and I looked at what you do, national local patients champions and independent bodies set up challenges, and I've gone all through that, and I'm just trying to think to myself, now what do you actually do that's constructive, that you can say you've got your values, listening to people? I'm sure that's wonderful, but what has come out of that, including anyone into the conversation, especially those who don't always have their voice heard? Now, where is the evidence for all of this? Acting on feedback and driving change, where is the evidence for that? And so partnering, okay, well, you're partners with government and other bodies. I just don't see where, and I see a huge bill of, what is it, 40-odd million pounds, and I just, 52,081,573. And I just think, what on earth is this all about? Because you see, when I look at it and think, well, where is it benefiting us? And I also then look at your name and shame. And I have to say, from a professional background in marketing, it's not a good communication. You're talking to a group who really play a major part in health and support. What we do with people who need help, the disadvantaged, the elderly, providing people into homes, and we've made that a major project. But I also have to say that we are the worst funded upper tier county council in the country. But there is other people who will have their difficulties. And I think without crystallising and saying, well, look, we're champions of what have we actually achieved? Tell us what you've achieved. You, by the sounds of all of this extravagant sort of systems and teams and everything else, you must have half a dozen at least where you could say, look, we've altered this, we've changed that, we've changed the NHS, because it's just a huge amount of money that we have to say, is this the key? Value for money? Is it value to the taxpayer? So the NHS is funded through our taxation, but our social services funded through taxation through council taxes as a vehicle, as well as other government money that we receive as grant. So I'm just concerned. I just looked at big numbers, and then I looked at quite a brutal, because when you look at the copy that you produced, trying to say, well, hang on, it's inadequate this, and we're losing money there, and we're not getting this, and we're not getting that, and you're still getting tens of millions, but it's obviously not enough. And obviously the NHS is really, people are questioning it more and more, how it operates and the value for money. Everybody cherishes the idea of a service free of charge. But, you know, when you're not getting the services and we're just putting up taxes, you have to think to yourself, now, you know, probably it isn't the best way, but I'd be really interested, because it's not just throwaway talk. I'd like to know of half a dozen real key things that this organisation's done on behalf of people to make a change in their lives. Thank you very much, Mr. Chairman. Thank you.
Wow, that was a long question. But I think I've got the general gist of it. So I think what you're saying is, because I believe that the papers submitted, some of them are quite local focused, and then you've had the national funding, which is Healthwatch England, which of course we feed into because we're part of that wider network. I think what you're asking is how we locally make an impact. I can talk you through the model and the way that we do that. And yes, we certainly have half a dozen, if not more, reports of the work and the way that they impact and what that has meant and what recommendations are meant for certain pieces of work across Leicestershire. But the model that we've adopted is very much about a critical friend approach to health and social care services. So we know that there are system problems, and what we're working towards are system problems. And although we are representing the voice of the public, we also are a critical friend to our key stakeholders. And so some of the information that we share at meetings and some of the conversations we have outside of those meetings feeds into the work that's already happened, which is formally around engagement with public, lots of events to talk to the public. Yes, when we're listening, we are capturing evidence. We have our own database system that captures the evidence of what's being said about what's working in a particular service or not. And we also link to our community groups and the beneficiaries that they serve and hear and take note of what's been said. So I'm conscious that I'm making this sound very simple. It's not a simple process at all. But what we do locally is we have that intelligence and we work with systems, health and social care as critical friends to feed back. And the reports and the enter and view visits that we do, where we go out with a team of volunteers, I think we've got 18 volunteers across Leicester and Leicestershire Health Watch, and do sort of enter and view visit where you go in and you assess a service, and we don't just pick one randomly. We've already got a local intelligence of the public and community saying that this particular service is not working for us because of this. And the whole point is, as an independent voice, to make some recommendations that help those accessing services, but also those that are delivering those services. So that's kind of like the local narrative. I don't know if there's anything that you want to add, Sarah, to that.
Yeah, thank you. I think to acknowledge probably where your question's coming from, I think the report presented has probably got quite a general level around Health Watch, and appreciate your question around the sort of what outcomes have been achieved locally for individuals and communities, and acknowledging that's perhaps not as in as much detail in the report as you might be wanting. Wondered if there might be an opportunity to bring that back at a later date with some very specific local examples, focusing on Leicestershire rather than having that National Health Watch emphasis.
I think it's fair to say, actually, this meeting has consistently been disappointed by the input from Health Watch. This report was asked on the back of the fact that we've had years of really quite, I think it's fair to say, inadequate reports, and the quality of the information, the quantitative quality of the information submitted has been lacking. And I think probably the frustration that was spilling over from Dan's question was probably built up from years worth of frustration about really where the value was being added, because to be frank, the experience that this committee's had so far has been that Health Watch is adding no value.
Did I come back to that? Thank you. Appreciating that and taking that on board, and acknowledging that you probably had previous reports understood. Would repeat the offer if possible with regard to this report, and as sort of as an officer not having an overview of the request of the detail within the report. If I could take back member specific questions today and then perhaps work with colleagues and work with Health Watch and with Val and come back with a more detailed report that perhaps addresses specific concerns, would really value the opportunity to do that and perhaps redress the balance.
I'm just going to quickly come back to Mrs. Richardson, and then I'm going to come back to Dan.
Yes, I think what's been coming out of the discussion is that Health Watch make various recommendations, but how is that then taken forward to actually bringing about action and change? And I think that's what this committee would really like to see, so that they can see that it's not just data collection and understanding what's going on. For example, the dentistry, we all know there's an issue with dentistry. Before that, it's what actions do you bring about through your recommendations? And do you actually follow through and keep a check when things are taking a long time to make those changes, that they're not dropping off the end of and not being actioned?
Yeah, absolutely. It's in very basic terms, if Healthwatch didn't exist, would anyone notice? Okay. Sorry, I'm Hardip. Sorry, the K's nameplate is still there, so apologies. Hardip.
Thank you for your honesty and feedback. I apologise that it's not quite worked out the way that you've expected it to, and you've been waiting a long time. Thank you to Sarah for suggesting that we come back with what you need. I would welcome that opportunity, because certainly there are actions that have happened from our recommendations. We're very connected with our service systems, and if we have an opportunity to go back and look through and bring that evidence for you, we would welcome that opportunity.
Okay, I'm conscious that I want to take this single item and then move on to other questions. So, Betty, was yours a fresh question, or was it specifically on this item? Okay, if you want to go first, and then I'll go Trevor, and then I'll come back to you, Dan. Oh, and I'll bring in Ross, then I'll come back to Dan, because Dan asked the original question, and we'll do the full circle. So just this is on this particular issue, not new questions.
My background is I worked at Loughborough University. I did research, and I find in your reports there's a lack of depth in terms of research. I don't know if the committee would agree with me, and I think that's where the flaw lies. Maybe if you go back and look about how you present the stuff and make sure that it's absolutely evidence-based. Sorry for saying that, Chair.
Absolutely, Betty. I'm at Loughborough researching as well, and at the university, and you know, when we're talking about reports that are submitted with quantitative evidence, and these are reports that are 20 odd pages long based on 25 responses, given it's a population of 1.2 million, you know, they are literally in research terms, they have no value. And it's quite difficult when you're receiving reports that are dressed up as being quite in depth when actually they're based on, you know, inadequate information. Okay, Trevor.
Thank you, Chair. It's a matter of how much bang do you get for your buck, really, in terms of, and where it's good that you're here, because as the commissioning agent, if you like, at Val for this contract, I think that you're in a unique position to understand this today, by accident, but it's a well-met accident, and I think that you would do very well to consider, if it's possible, to set specific targets of achievement. Smart targets if necessary, that's okay, but so that you could then commission on 4 or 5 items which are mentioned in here, and say, so what do you expect next year in the 12 months hence to gain and to have improved, and how? That would then be an absolute gem for those workers, those volunteers who are going in there to actually work out and be able to justify what they're doing in the back of their minds, and so the target is well understood. That's it. And then, you know, in 12 months' time, those targets you can analyse, and they won't all be achieved, I don't suppose. Or then again, maybe they could be. But at least a target is an important thing in my mind to have. Okay, thank you, Chairman.
So I can, having had the contract sit at Val for just coming up to a year, obviously after naturally it's a mobilisation year, it's a transition year for Healthwatch, and we're going forwards looking at what's worked, what hasn't. So this is actually an ideal opportunity, and like you said, by chance it's happened. It's actually great for us. But I can confidently say that there is evidence. Whether it's not been quite presented in the way that you would like, I can certainly go back to look through what we have and what isn't there or what's missing. We can certainly revisit that, but I can say that we've got information, we've got database. There's more than the 25 responses. They've just been pulled out because that's you know, a way of report writing that hasn't worked on this instance, but we can certainly look at that. So I'd be more than happy to do that.
Thank you, Chairman.
Okay, I suspect some of those reports, unfortunately, aren't based on more than 25, because this is not a one-off. But Sarah.
No, it's just to reassure the group actually that we are working with the provider to make sure that we've got the smart targets as suggested, and that we've been reviewing targets and KPIs quite closely over the past few months and since the contract moved across. So just reassurance really that is in hand, something that we'll be taking forward and taking your suggestions back. So thank you.
Thank you very much.
Thank you, Chairman. Happy to hear that.
Okay, thank you very much, Trevor. Ross, do you want to go next, and then we'll come back to Dan?
Perfect, thank you. I think Betty wanted to say something as well.
I wanted to highlight a paragraph, if I may, and really, it's a paragraph on, sorry, my eyesight's not the best, page 42, and you talked about the chair going to, on the local radio station, talking about delays in emergency care at A&E and about you visiting, but you went to say, your final sentence there, we revisited the department in September 2023 to see what improvements have been made. What? You know, can you see my point? It needs more, sorry, Chair. From my background, I think this needs more evidence. Thank you. Sorry, Chair.
No, thank you, Betty. Back to Ross.
Sorry, thanks. Yeah, I mean, I think most members here today have mentioned that the kind of cost benefit that we're getting for what we're putting in. I appreciate it's a statutory service where we do have to provide it, but at the end of the day, £300,000 is a lot of money when we're making cuts in other areas of the council, and so taxpayers quite rightly going to say, what are we getting for that money? To put it into perspective, you know, as sort of local politicians, we all go out and knock on doors and chat to our residents, and last weekend there's a team of about 8 of us in my division, and we probably spoke to about 250 people, you know, and that was within 3-4 hours in the morning with me and some friends and other people in the community. So when we look at the report and, you know, getting £300,000 and you're saying, well, you've spoken to 200 young people about mental health, or you've handed out 500 flyers, I just don't think quite we're getting the bang for the buck that has been said. But I'm going to move on from that as well, because I think other councillors have made that point, into sort of advocacy. Kind of what are we doing with the information that we're getting? I don't quite see in the system where Healthwatch sits, because if I look around, it's not a novel idea to consult with the public on what services they want. Okay, so as has already been said at the start, you know, I work as a dentist. We have the local dental committee where dentists will talk about the issues that we're facing. You don't have to be an expert, like Louisa said, to know that access to dentistry is the biggest problem. We've got people that are on the GP's, you know, patient practice groups, or whatever they're called, PPGs. I'm supporting Hinkley having a community diagnostic centre. They've done a massive consultation with the public. So I'm just worried that we're adding an extra bureaucracy to consult yet again, whereas actually people want to see results. You know, they want the money to be spent on new buildings or new staff members or this and that. The other thing is are we just spending money for the sake of spending money? Because I was very grateful. Healthwatch were at my local summer fair in Barwell last summer, and I went up and spoke to them and said, oh, you know, how are you finding things? And they weren't taking the opportunity to survey members of the public about, well, how's your GP service? Or, you know, have you had your vaccine for COVID, or whatever it may be? It was, oh, here's a leaflet about the work of Healthwatch. This is what we do. Why don't you get involved? Which is great for Healthwatch, don't get me wrong, fantastic. But I feel like at the end of the day, you're not accomplishing the aims that you're setting out to achieve. And there were lovely people there. I don't know if they were volunteers or staff members. They're absolutely lovely people. But I just don't quite see what the point of them being there was if they were just going to talk about Healthwatch.
Okay, so what we are doing at the moment is priority setting for Healthwatch. And I think I mentioned earlier that there's those system concerns, which you've mentioned, that are coming out through the work that you do anyway. But as Healthwatch, what we want to be is an advocate for those things that don't always come out, for actually the real issues that affect people. And we're seeing a kind of crossover between something here that is a system issue affecting people, or their mental health, and leading into other things. And we're quite interested in that at the moment. So some of the engagement that they do at that summer fair, yes, we have proactively been looking at questions that they can ask. and or not just talk about Healthwatch, but actually some of the surveys that are already in the system and what added value Healthwatch brings to those questions. So certainly, yes, what you've raised, we've acknowledged and noticed that as well. So there's a Sarah, please do chip in, but there's a proactive effort in looking and reviewing of what's worked and what hasn't worked as we've had a year with Voluntary Action Leicestershire. I would just like to sort of mention that I came into post, not that this almost sounds like excuses, but it's not. But I came into post in October. So this actually is a good opportunity, because when you get somebody new in, they look at things slightly differently, you know, a new contract, a new provider, a new person in post. So all of those things, I would like, thank you, I acknowledge. And some of those, yes, we've looked at already as the provider. You know, what is it that we're saying when we're going and engaging? How many people are we engaging in 300, you know, in 3 hours, as you've said. Have you got anything else to add? Thank you.
Yeah, if that's okay, Chair, not to jump on the newbie bandwagon as well, but just say it is a good opportunity as well, and we appreciate the feedback around that, because I think as a commissioner, we're finding our way through the balance between the National Healthwatch framework and guidance and what we're looking to fulfil in that statutory obligation, feeding in nationally and national important issues, and then balancing that with locally important issues. You mentioned dentistry earlier, which is the classic example. Everyone's going to mention dentistry to Healthwatch. That's probably not something that we're going to solve on a local level through Healthwatch feedback. So maybe as a, you know, we can help shape and guide that into areas where we can make more impact. And just to come back on the finance point as well, I wonder if if we are able to come back with a report, we do a bit more clarity around the way that Healthwatch funded and the way that the money goes into that, and the split between city, county, obviously joint funding arrangement, and that bang for the buck. So obviously not that whole amount isn't for the county as well. So perhaps a little bit more sort of explanation around what we're doing with that as well.
So the split, I think, between county and cities is actually already in the report, because the sort of the name and shame financial paper, which was tagged on to the end, which I have to say I agree is probably not appropriate, because it's a national produced paper, you know, raises, I have to say, also questions about funding, because actually it's quite clear that some authorities are not funding, and yet there's no recourse against them, which if I was any funding authority, I'd probably be looking at that thinking, okay, that's interesting. We don't actually have to pass this on, and we don't actually have anything coming against us. So I'm not entirely sure it's particularly helpful for Healthwatch to flag that. But the split is in there. It also obviously adds in the Rutland part, which is about £70,000. For some reason, this report, although I'm assuming probably covers the whole of LLR, because we certainly get Healthwatch people turning up to the joint scrutiny from Rutland, that this report only seems to deal with city and county.
So just to come back on that, Rutland has its own Healthwatch. Originally, when we went out to the open commissioning process, we were going to go LLR. Rutland decided not to be part of that process, so we went Leicester County, Leicester City.
Okay, so that's useful to understand, because it's not particularly obvious the way that it operates in that case. So that's interesting in its own right, because Rutland are the only people that ever send anyone along to the Joint Health Scrutiny Committee. I have to say, not always constructively. I think, which has been noted by the Joint Health Scrutiny as well as this particular County Health Scrutiny. So that's something that probably you may wish to also accept or acknowledge, that the Healthwatch brand is not particularly positive, or not positively acknowledged on scrutinies.
Can I just chip in here just to say that actually what this report, like you said, it wasn't very helpful, actually, that national report. What it didn't include, which was quite disappointing, is there is information through the network that says, for example, Leicestershire is doing very well at this, and I know some of those figures, I know some of those sort of targets and the reports that have been produced and had an impact in Leicestershire. So once again, an opportunity to kind of get you that information, if you would be happy to. I would like to take that opportunity, because that report doesn't really highlight the things that Healthwatch Leicestershire are doing really well at that other areas do not have, and some of those are around, you know, a really strong Entram View project.
Okay, I'll sort of summarise at the end, but I'll include some of those points as well. So I appreciate this is sort of going around. Brenda, are you on the same point? Because Dan is going to come back and finalise his question. Go for it. In that case, Brenda, Dan can wait.
Dan, you can wait, Dan. You're worth waiting for. I'm sorry, I didn't catch your name, but thank you very much for coming along. And I would not like to have been the person that had to defend this report. It is appalling, to be quite honest, and it doesn't do the service much credit. You're saying contract, you've just had it just over a year coming up to, and it's moved across from where to where? So where did it move across from?
So previously we were with, it was EMS. I'm gonna fail to get the acronym to you, but
okay,
it was another provider. Yeah, it was another provider which supported a number of health watches.
So obviously these Val would have tendered for this.
Yeah, it was an open tender process.
Okay, open tender process, and I'd probably like to see that tendering and what your you've put through that you will do that EMS or whoever they were didn't do. Looking at your national statistics here, it's 40 staff. So over the whole country, you have 40 staff. Surely that's not right. Work with the public policymakers, partners to improve care. Is that nationally right? Well, no, it says, well, full-time equivalent staff deliver Health Watch. So I'm not quite sure what it all means locally. So nationally it's just doesn't work for me. The whole thing doesn't work for me. And then it says at the bottom, on average, each Health Watch has 4 workers. So our Health Watch has got 4 workers.
So I think this paper, the page that you're referring to, kind of covers a bit of a national average picture. So that's what it's trying to do. We at Health Watch, can I just say EMS was an outside provider? Yes, it wasn't local to Leicester or Leicestershire. We have 6, that includes the manager for your local Health Watch.
It's still expensive for 6 full-time equivalents, and obviously you've got the volunteers. So Leicester City is county councils nearly 160, city just over 140, and I see Rutland is 72,000 to that. You say you mentioned key stakeholders. Well, we've got no idea who those are. So if you were coming back with a review, I'd like to know who your key stakeholders are. You've got you said earlier on our community group. Got no idea who our community group is, and you've got 18 volunteers. How have those volunteers been sought? Are they vetted? Are they, where do they work? What do volunteers do on that? So as I say, but with just general details that we haven't got, it's just it is difficult. And then how we carry out functions, enter and view programme, that doesn't mean anything to me. Information and signposting. So as I say, I think we've established that it's a poor report. And I would welcome a full review of Health Watch. And I think your comments on if it wasn't here, would we notice, have got to be really strong in this, because a lot of the work we already commission, we do dentistry at the county council. We scrutinise that in quite a lot of depth. Immunisation, if we've just seen, vaccination. So I just want to know what Health Watch do that Leicester County Council, Leicester City Council don't do. That, we're already covering it. So probably we should have had their contract and sort of took it in-house. It's something probably to think of in the future. But thank you very much, Chair. Thank you.
Thank you very much. Should we come back to Dan to ask the sort of closing bit of this particular question, and then we can go on. So Dan, you've been waiting.
Thank you very much, Mr. Chairman. First of all, could I thank you both for your forbearance? Maybe you realise now why your colleague didn't feel very well. She read the document. It's awful in all particular ways, and I wish you luck with that. But I just felt it wasn't professionally presented. And with this sort of whinge and whine about all the financial elements to it, is it really our concern? You know, if we pay what we pay or whatever, do you need us to scrutinise it and say, oh, no, we're paying you far too much? So there's incompetence within the whole thing, really. So if I think you can come back with proper understanding and we can understand better what you represent and what you've achieved and how can we value it, because is it value for money, etc., etc. Because I think we're probably getting to the point, I know there's a legal assumption in all of this, but I think government's going soft in some ways because they can't keep funding local authorities and they're sort of pulling up the ladder. So, you know, how do we carry on with it? So anyway, I thank you for all of your brave representation and hope that you're not offended, because we've not meant to be horrible in any way. We just feel very concerned and think, well, this is a document that should not have appeared here today. Thank you very much, Mr. Chairman. Thank you.
Thank you. Betty, do you want to come in quickly?
Just very quickly, I do have a little bit of sympathy for you in the sense that you are struggling in terms of being able to fund the service. You're basing it according to this on page 50, and I'm reading it without my glasses, that you're not being able to deliver against your targets because of the funding is not adequate to do that. Is that the case?
I don't know whether it's massively too much.
Page 50.
Is this in the national?
This is the public agenda packet.
John.
Sorry.
Can I come to Mike? I think he's got a figure.
And just on that, I've just been trying to work out the figures, actually. If I've got it right, reading the covering report, the contract value jointly across Leicester and Leicestershire, I get it to total 299. And then the two bits of money added together that we receive comes to about 310. So if we are short, it's by about 11k across the two authorities. Is that right?
Yeah, do you want me to come back on? So the funding comes from the Local Reform Community Voices Grant, acronym there, and that goes out to fund Health Watch, Doles and ICAS. The city-county split is that we have 52% of the total contract, so our amount is just shy of 157,000. And we use all of our grant for that. Other authorities receive the revenue support grant, which they use to top up. We do not receive that, which is why we don't have anything in addition to that and our CVS grant money in there.
Which makes the fact that we're sort of named and shamed in the national report slightly unfortunate, because actually we are handing over what's actually in the grant, which again, going back to, it's unhelpful, really unhelpful.
Don't most so.
Yeah, just to echo that, we, you know, as Commission, we do share the concerns around the report, and we would like to work with Health Watch to improve that going forward.
Okay, can we have one last point on this one, Brenda?
Just a quick question. Had we not scrutinised this today, had Val already recognised that there was something that needed to be done to improve the service and make it more fit for purpose?
Yes and no, if I'm going to answer honestly, because I think the work that the staff are delivering is actually very high quality. The way that the information might be presented or yes, there is improvements. I've looked at that. That's the first thing I looked at when I came into post, and working very closely with the commissioners on that. But some of the information that you haven't received, that you've talked about, how volunteers are recruited, the financial split, what that means. Yes, I think some of that we can strengthen. That actually report writing, demonstrating the evidence, and there's always improvements in all services. So there's lots of ways that, you know, a work plan has worked and some ways that we can make the improvements. So yes, we already had. Like I said, it's the papers, which is possibly an oversight on Val's part, but the first time I looked at the papers was when they'd been sent out and I was coming along to this meeting. So there's something certainly we can do with that. But in answer to your question, yes, but there's some things that I know I can confidently answer, put into a report and send to you that I've already got that hasn't really been shown here.
I just need to come back once more, Chair. So if Val are overseeing Healthwatch, I would have expected you to have had this report before we did.
So as a model for Healthwatch, because it's independent, Voluntary Action Leicester has its own Val board. Healthwatch has its own Healthwatch advisory board. So the papers would have gone to the advisory board. Now there seems to be a step here that's missing, which is that actually they should have come through another step, which is myself, and that bit didn't happen because although we've made a lot of changes from it moving out of ECS, which was a provider that's national based in Staffordshire, some of the things we haven't quite ironed out. So that was their process. It went through the advisory board and not through them. We need to look at those. Some of those we've managed to resolve, which was the whole point. We went for a tender and the tender was a whole amount. So it wasn't split when we applied for city county. We went for the whole amount. Some of that the whole point of why we went for it was we felt that Healthwatch needed to be more local and it needed a local provider and to have that local impact, which is one of the reasons that Val applied.
Are the staff the same?
Not all the same, no. We had 3 maybe move across. We've had a recruitment drive during this time as well. So we recruited, so yeah.
Okay, thank you very much. Look, I'm conscious of the fact we've probably gone a full cycle of everyone. I think Mr. Charlesworth, the only person who's actually stayed silent, so I'm expecting him to come back with a. That's okay. In that case, that's fine. That's okay. An observer is the. No, that's fine. Look, this is all constructive. This is all constructive. Mr. Newton, do you want to come in with a quick question?
It's not so much a question, it's more a statement, because if you look on page 60 of the report, it says a local authority is required by legislation to commission local health watch for their area, and it gives a list of what they do. So really, could I suggest that you go back and look and see if that's exactly what you're doing, how you're doing it, and if you're doing it the right way. For us as a local authority, I think there's some questions you need to go and look at yourselves. Thank you.
And actually, in addition to that, the one useful thing that was actually in the national report was actually on page 60 was the comment that the obligation of the local authority under legislation is to commission local health watch for the area to exercise its functions under this part, as to secure that the arrangements A, operate effectively, and B, represent value for money. So I think the operate effectively and value for money absolutely is what everyone's talking about. And Mrs. Eaton, I know you made that recommendation, which is actually we look at those 2 points, particularly to make sure that as far as the scrutiny's body is concerned, but also Mrs. Richardson sitting there as part of cabinet, that we actually understand that the commission of Health Watch has been done with those 2 things in mind. I've just had a quick look through the Health Watch website locally to see what reports have actually been issued, and I think there have been 6 reports issued in the last 12 months. 3 on asylum seek and 1 on dementia, commissioned jointly with Rutland, and I think 1 on Somali community as well. So I think it's, again, the effectively and value for money part is quite important, because this is coming out of, as I think many have said, as this is coming out of the ever smaller budgets that I know the county in particular have, but also city as well. And the value for money becomes ever more important. Okay, look, are there any additional questions? I think we have, to be fair, we have vented all of our frustrations from the last 2 or 3 years. So apologies that you've sat there and had the venting at you, but hopefully useful in a weird sort of way. You probably would not have heard about this meeting any other way. So useful that we've had the opportunity to be very, very honest with you. And hopefully you'll come back with a revised paper and also, as I said, to address from an LCC perspective, particularly, that the two issues about value for money and effectiveness are addressed, because that is the obligation on us as a local authority. It's not BAU. It's actually an obligation on us as a local authority that we are commissioning with those two things in mind. If through officers and cabinet it's viewed that actually we haven't actually commissioned with those two things in mind, or we're not able to actually demonstrate, then that's something that we need to look at. We only have scrutiny powers here. We can't actually instruct, but we can actually ask the cabinet look at these items. And maybe with that, I'd move that we actually ask Mrs. Richardson as a cabinet lead to oversee that review, and that she's involved as well. Are you happy with that, Brenda, as well?
Can I just clarify? Is it 2 years come October left on the contract?
By the sounds of it, there's been one so far, so there must be 2 to go. Is that right? Okay.
Yeah, there's one of 3.
Okay. Right. Are we happy that what I've just asked is a recommendation, and you're quite happy with that as a recommendation? Excellent. Okay. The committee is happy with that as well. Okay, good. Look, thank you very much, Hardip. Thank you very much, Sarah. Appreciate it's been probably a long 30 minutes. Might even have been an hour, but hopefully not wasted, and we look forward to seeing the response, but also likewise through Mrs. Richardson as well. Hopefully we'll have a chance to think about this as well. Okay, thank you very much. We'll now move on to the next item. Thank you. So we're now on to the last item of the day, which is health performance update. So I can see in front of me a large picture of Victoria. So Victoria Rice, who's our research and insight manager here at County Hall, and also we've got, yeah, we're preparing for the. You thought the last item was bad, David. I seriously. David Baxter, who's here from the Integrated Care Board. So we always leave the most contentious item to last. So it's good. No doubt Victoria will lose a connection to us any second now. So it'll be you, David, on your own. So look, thank you very much. As always, we absolutely take these papers as read. You'll be relieved to hear. But there's plenty of data in your report that I know some of it will be familiar from our discussions at Scrutiny over the last 12 months. We're absolutely aware of where some of the figures have been going, but also some of the plans sometimes to recover them. But it's very useful to actually have this report coming to us so we can actually see some of the points that no doubt you are also sharing concern about. Can I ask whether either of you or both of you want to have 30 seconds just to highlight any particular issues in the report before we go into detailed discussions and questions? Okay, I think Victoria's pulling a face that indicates not from her either. Is that right? Okay, right. Okay.
I can't see David.
Oh, right. Okay. David was looking at you. So I think the two of you were being able to sort of stare each other up. Anyway, right. Look, okay, that's fine. We've got a lot of data. We've got a lot of information. I know there are some questions coming through. So we're going to start with Dan. Then we're going to go over to Ross. I know Brenda's got a question as well. So let's start with Dan in that case to start off with.
Thank you, Mr. Chairman. Good afternoon and welcome. Hopefully you're going to enjoy this discussion and we're going to be enthralled with your comments on it. I just don't understand why you plan, when we look at efficiency and we think, well, 100% is the goal. We all know 100%, but you start at 77 and then an actual of 65. So I just, that's on page 97 to help. And I just begin to think, well, you know, that is dealing with blood pressure, which is really important to lots of people if they're unaware of it or suffer badly from it. But it's the whole concept of how you put 77 lower down, 60% is a plan. You know, so if you sort of create this dimension that you know, this is where we're starting. We don't begin at 100%. We just want to think, well, if we get that far, we've done well. You know, is that really what we should be saying to the public? Because that's what the public will presume, and we do as Scrutiny committee today, is to look and challenge and think, well, you know, where is the value in this? People smiled and said, you know, question, well, where's the value? But I mean, it is all public money, and we're accountable all the time to our public as you are to all of your public. And I just don't understand why, because obviously if you put 100 in and you're achieving 65, I can see, I think we understand the ethos behind it, but is it really fair and true? Because it's a plan. If you're only planning to achieve 77, well, don't be surprised because you've got 65.8. So, you know, is it really fit for purpose, this thing? Is it real, proper planning and targeting? Because your levels are so low that, you know, even if you fail, you just miss by a little bit. But really, we're about the 100%. Where did that go? Thank you.
So thank you. I mean, that's a very good question. I think to assure you, these targets, they are set as part of a set as part of a big process, and where they are low, it's set, I suppose, it's set by looking at where we are now and what's achievable in year. So on a lot of these, you're never going to hit 100%. There's always going to be reasons why not. And I think what we've got to say is we've got to set a trajectory that's going to be challenging but achievable. And I think we're always going to want to aim for that 100, but it's really that question of where are we not achieving what we set out to do, and therefore where do we need to focus and put remedial actions on that? So that's, I think, where they, you know, there's a whole range of targets, and some of them are extremely high, so elective, it's way over where it was, and some of them actually it is low.
Mike, do you want to come in on this?
So remind me, though, it's probably worthwhile reminding the Kids Committee which ones of these are nationally set and which ones are for us to determine a kind of a plan to get to where we want to get to. I'm thinking the A&E 4-hour targets obviously nationally set, but some of these ones I'm not certain if we've got local discretion in terms of where we want to go for.
So thank you. Yes. So the elective target and the ED, the A&E are nationally set targets. The rest of them are locally developed.
Okay, Dan, do you want to?
Yeah.
Trevor first, and then Dan.
So we need a trajectory, and on page 99, you thankfully provide us with some sort of trajectory next to the red, amber, green, going one column left. I'm not sure what dot stands for, but I do know what the arrows stand for. They either mean improved, level, or in the red, not improved. So there is a trajectory there which shows most are improved, if I may sum. The dashes, I'm not sure what they mean. No data. That's hard. So you rely upon previous data. But so it's just that it's hard to find a trajectory, and we then trust you that next year, when these come along, or next quarter when these come along, you have moved the goalpost accordingly in terms of smart targets. And I need to ask, are we doing that on a regular basis? And what is our general trajectory like?
I think Mike's just going to quickly come in on this one as well.
Yeah, just on this. So I suppose I would separate out the NHS targets, which are pages 97, 98, which is the plan one. 99 is the public health population indicators. That's why they're all green. Judge. But yeah, so and we don't, funny enough, we don't set targets for those because there are no nationally set targets, but of course we do the best we can, and then we measure ourselves against our comparative performances, which is the England average, and DOT's direction of travel as well. So they are slightly different, but David, you might want to comment on the NHS ones.
So one thing I was going to ask about today is the format of the report, and this is a report that I've inherited. We do, of course, have the full backing with the trajectories on and the targets and showing how those change through the year. And I suppose I'd welcome the opportunity to work and I suppose align this report more to what we're doing internally.
Okay, thank you very much. Before we come back to Dan for follow on, Betty, this is on the same issue on data. I'll take that as a separate question in that case, and then we'll come back to Dan on this one in that case.
Yeah, thank you, Mr. Chairman. So just going back to 97, that page, you've got 26, 26, 44, 77, 65, 77, 75, 77, 67, and 60, 61. So you actually got your green there. You're doing well on that. But 1, 2, 3, you've got 3 blocks there. They're significant, and you know they're low performance results. I know what you're saying. You're set, and I've heard some set nationally and everything else. But at the end of the day, I like to see it's 100%. We know what we're talking about. But if we're setting then another figure because you're making allowances for whatever, how are we supposed to understand it, and how are we supposed to sort of say, well, where are we going with all of this? Because they don't look that good, do they? Apart from the 3 in green, you've got 1, 2, 3 in red. So, you know, you could say, well, hang on, we're halfway there, but, you know, is that the reality? Because that's the bottom in green is 60 and you've got 61.8, but it's not 100%. All I'm trying to say is numbers are the key to all of this, and the numbers talk, don't they? They don't lie. It's, you know, so we know where we are with numbers, but we're not getting 100%. I find this a problem because I just don't understand why you can say, well, that's the best we could do. Is that the way you handle it? Because really, we want 100%, and if we knew you were performing 77% instead of 100, we'd all be thinking, wow, you know. But if your 77 is your target and you don't even hit that, you're 65.8 on one of them, you know, that is really not a good service, is it, to be honest? Thank you, Mr. Chairman.
So, I mean, where I think those 3 do require improvement, I think I would I'd question on whether it says it's a good service or not. I think all of these targets are going to be challenging. There's going to be ones that are going to be it's going to be easier to hit than others. I think what I will do, I've got some more detail around these 3 targets in particular. I'll follow up afterwards with that. I think.
And back to Mike.
Just on that one, is it worth, could you just include something about how we set the targets? I mean, it's been a long time since I was involved in setting them, but there is something which I think underpins this, which would be worthwhile sharing, which is almost, it is the, where are we now? Where do we want to get to? What do we think is the realistic stretch on where we are now? You know, all those kind of management assumptions that underpin the numbers itself would be really useful.
Okay. Do you want to come back on that one now, David, or?
Yes, I can do. So yes, all the planning and target setting is going on as we speak. So I'll be able to come back and give an update on that, how the targets are set.
Okay, thank you very much. Right, so Mr. Charlesworth, is this on this point on data? In which case you're allowed a question. Go for it.
Thank you, Chair. I don't see the value of having 100% because then every single one of these blocks would be red. I mean, we know at district level, in the councils that we're in and possibly here, we have KPIs which are set internally. There's probably an argument for setting KPIs externally. But you know your organisation better than anybody else. You know what the capacity is. You know what the challenges are. You know what you can possibly reach. I just don't see the value in having everything red if the target's 100% for everything. I take Mr. Harrison's point. It does look odd, 65 against 77 and all of that, but we know where you're trying to get to. Perhaps a bit more explanation on what the 77% is made up of. You tell us what your challenges and capabilities are, and we get a better understanding of where you've got that original figure from.
Okay, I think that we're going to get that back by the sounds of it from the comment that Mike made and David said. So we'll get a bit more information back and we'll understand I was just thinking about personal targets, and maybe I should have a personal target to actually run 100 meters in 10 seconds. I'm not entirely sure that's probably going to be. It might be technically achievable, but I'm not entirely sure I'd probably ever achieve it. So maybe 15 seconds would be my personal target. But anyway, look. Everyone says data as if that's the key word for suddenly thinking. Ross has been waiting patiently to ask his follow-on question. You have no idea. You've given up, haven't you? In that case, Brenda, you can ask something else on data.
Thank you, Ross. More time for you to think. Okay. So on the on 95, page 95, you've got the community health services there, plus the well, we'll go with that first. It's to be confirmed. Have they been confirmed somewhere else?
So we've been working on these. So we do have data for this. We are. It doesn't look like we're hitting our targets, which is good. We are, I suppose.
Sorry, wait a minute. It doesn't look like you're hitting your targets, which is good. Oh, it does.
It does. Yes.
Okay.
No, I think we want to be sure that the information's right before putting figures out there.
Okay.
So there's been a process of going through and working on that data and making sure it's right. So that's why these aren't reported. We do have local data which is being monitored. It's just that we're not. It doesn't meet our threshold of confidence to put it into the public domain yet. It doesn't mean it's wrong. It just means we need to look through and make sure that's right.
Okay, thank you very much. And the other one is for that is what are additional role reimbursement scheme, 26,000 of them, continue to recruit 26,000, and I appreciate that's nationally. Additional roles reimbursement scheme. What is that? Same page.
95, primary care.
On the primary care. Could you just explain that a little bit more for me, please?
Yes. So this is recruiting, I suppose, enhanced roles within the primary care, which they can fulfil jobs that GPs have traditionally done. So it's there's a big drive to increase that nationally. Might have some local data, but I can certainly send that through afterwards.
Okay. Lovely. And I know sometimes when I speak to the doctors, I'm just talking to a pharmacist, a clinical pharmacist instead. So it's those sort of roles, is it, that support?
Yes, exactly
GP?
those. Yeah. So
Yeah.
it's I suppose it's to say actually the number of. To meet the demand in primary care, actually we've got to think differently, and as an NHS as a whole, and actually pharmacists and nurses, physios can see patients, and it means they get the treatment they need, but without needing to wait for a GP.
Okay, thank you. And my last one on the data, before you press your button, Chair, steady on, is instead of probably the heading plan, you just change that to target percent. And that would make it all obvious to what it means. Thank you. That's it.
Thank you very much. Mrs. Richardson's going to claim there's something data in the sentence, and it means that she's going to say something.
No, I was just going to say, if you're coming back, would it be prudent to put against some of the reds what, in a few bullet points, what you're putting in place to actually address that?
Yeah, so I mean, this summary is taken from a bigger report that we've been developing through the year. So the 31 metrics that are here, a lot of these are new for the year, which is why we've been, I suppose, why there are gaps and we're struggling for data. But what is within the report? It's got the full trajectories, it's got the actions that are being taken, it's got the good news, and it's got the explanation of actually what we're doing to bring things back on track. So, I mean, I really like the reports because it's got everything in a nice, concise way. And I think my question is, do you want a version of that here? That
we're more than happy to read. And if it means that we ask fewer questions as a result, then that's probably better for you as well. So yeah, it would be good to see it. Excellent. Right. I think nobody's going to mention the word. You're not going to say data, are you? Is this a fresh question, Betty?
It's really around.
No.
So
on a bloody button as well. So apologies. Right, Ross, you better have a question.
I guess every question's on data, isn't it? 'Cause it's a report on figures.
No, well, okay, I know, but it's on a fresh issue.
I think so.
Not on Dan's
issue.
issue.
A fresh issue. Okay, I've got a fresh issue. Okay. Not to I forgot what I was going to say now. when it comes to compared to the Health Watch report earlier, we usually have John come to these meetings. I mean, he's the COO, is he? He's got a fancy title in LLR NHS, and he's always been upfront and honest with the Scrutiny Committee about where the faults are, where we're prioritising. And one of the things that I remember that he said previously was that in Leicestershire we were doing poorly for people waiting for operations. And he said, actually, do you know what? We could do the easy ones, maybe even waiting 50 weeks for an operation, and it's easy to do, and it'll bring the overall numbers down, but that wasn't ethically right. We should be prioritising people that were waiting the longest. So I'm glad to see now, and can you just reinforce my understanding that actually we're going in the right direction here? Because it says 0 people at the end of last year were waiting over 104 weeks for an operation, whereas I think last time this report came, there was people in that category. So we're moving the bell-shaped curve, I guess, towards the left, whichever way you look at the axis, where people, you might have more people waiting short amount of times, but we're tackling the right-hand side of the curve.
So absolutely. I mean, the elective waiting list has been a big success story. I mean, I think we started the year with probably the worst in the country, or pretty close to it. And actually, yes, as you say, we've been tackling people who've been waiting the longest with the most severe conditions. So it's been the 104s have gone. I think we are aiming to have nobody waiting over 65 weeks. Now, obviously, with reference to the comment earlier, we're going to keep at this as it comes down. You know, we're tackling the easy stuff, but we're also tackling the hard stuff. So it's we're looking to continue to reduce that waiting list through the year.
Amazing, because I think kind of waiting times for operations is obviously one of the things that really gets to patients and a real priority for them. The other priority is going to be how long they're going to have to wait in A&E. Can I just get some clarity? Because by my reading, I probably read it wrong, but there seems to be 2 different targets. In the main report, it says there's the 4-hour target for A&E admission, of which case the national target is 95%. But if you go on the appendix, it says the plan is for 76% of patients to be seen within 4 hours. So again, there's a discrepancy, because I understand when you have a local plan, that can supersede national targets, but I would have thought the national target would take precedence.
So, I mean, that was something I was going to raise about the plan and the target. So I think the national target is 95%. I think you need to, when aiming for something, actually you need to look at where you are now and get your trajectory there. So our trajectory by the end of the year was to get to 76%, and that's been agreed with NHS England as a challenging but achievable target. Now, you'll obviously be aware. ED targets has become a big priority for the NHS to achieve. So there are, I think, there's a lot of action to try and achieve that happening at the moment.
Perfect. Then my final point, I just echo what Louise said about getting a little bit more information behind some of these numbers, because it said, actual last time was 58%. Now, if it was 48 previously, then we can praise you. If it was 68 previously, we're going down, then we'll all have a go at you. You see, so a little bit more information will be helpful in future reports, see kind of what the direction of travel is and where we're going.
We can absolutely provide that. I can tell you for the A&E target, it's been at around that level through the year. So the plan was to stay at that level and then within the last 2 months recover. Now, I've not seen the latest information. I think that will be extremely hard given the winter pressures and the strikes and the ongoing problems with there, but there's a lot of different schemes being put into place to achieve that, especially around same-day emergency care and the continuing work on discharges and flow.
Okay, thank you very much. Now, I think I've got a follow-on question from Betty coming up soon. Also, Trevor has pulled out. Brenda, I think you still had a question on falls. Any other questions? Otherwise, we're going to take Betty, followed by Brenda in that case. So, Betty.
It's a very quick question on page 97. It really is about blood pressure readings, which are quite quick to take. I mean, I've got a machine myself at home, and the blood pressure reading shows up, as you will be aware, a lot of issues. I wonder what can be done to increase the number of blood pressure readings that can be taken.
That's a very good question. I'll have to say that one outside. So I've just looked in the other report, and I can see the hypertension has been continually improving. I'll get some more information from the rest. I'll send that.
That's fine. It's just something. It's very quick to do, and it might solve a lot of problems further down the line. Thank you, Chair.
Chairman, I walked into my chemist and I had a bloodshot eye, and he took one look at me and said, "Sit down, we'll do your blood pressure." That might be an answer.
I do me all.
I was going to say, unfortunately, it's an age thing as well, Trevor, because I've also been insisted that somebody suddenly they were interested in my blood pressure. It was that, or it's chairing one of these meetings. I don't know, but anyway, apparently there was a problem. But okay, Brenda and falls.
Thank you very much, Chair. This is on page 93. It's just the emergency hospital admissions due to falls for people aged 65 and over. You're got what the heading is. The target Q2 is 1,628.1, and then it's currently now 471. So it's gone down drastically, which is good. But the text doesn't seem to coordinate with that.
So I was reading through this in response to your question. I picked up on that as well. So I think that is a typo, and we'll go back. I can. So
if it's a zero or another figure's been missed off, then it's gone from 1,600 odd to 4,700 odd. So it's increased. Yeah.
Yes.
Thank you.
So I can tell you for falls. So there's been a project to look at falls from care homes, and actually that has so falls from care homes are about a third of all falls, and from putting the project in, that has gone down 25%. The latest information is down 50%. Although as somebody in BI, I'd never take a single point and go that's achieved, but it's been consistently reducing. So and the work is on happening to actually roll that out to the rest of the population to allow people to self-refer into that programme.
Okay, so we've got Mike, but also Philippa has suddenly appeared on the screen. So with our hand up, so we'll go for Mike and then we'll go for Philippa.
I'll let Philippa come in. I was going to say this is something to do with small numbers, just a quarter's worth of data on emergency admissions in the under 65s. But Philippa, do come in.
Yeah, no, the plan for the emergency admissions is a full year plan rather than a quarter plan. So the forecast for the year end is 10% under the 1,600 and sorry, I can't put that figure in front of me, but yeah, so that is an annual plan rather than a Q2 plan. It was a misheading on that column for that particular metric.
Okay, so well picked up from Brenda. but just a tweak on maybe what it's referring to in that case.
So if that is a quarter planner for 400 odd, then
That's the
four
quarter
quarters in a year. So that
That's
would
the
go
actual
up,
for
yeah,
the quarter. So if you
Okay.
multiply that by 4,
Yeah.
You get it.
Yeah.
Lovely, thanks.
Yeah.
So at the moment, it's very much a finger in the air based on one quarter, but we need to watch what's happening. Okay. Look, okay, that's... come on, Mike.
In my mind, then, if you times 471.5 by 4, the 10% is with 10% higher than we need to be to meet the 1,600 target for the end of the year.
That's what. Absolutely. Okay. Look, I think we're all in agreement. We understand. Clear. The data is clear. The data is clear.
As well.
Clear as data is always clear. No. Victoria's the microphone's broken, hasn't it, Victoria? Is that right? Your microphone's broken. No, you can speak.
Mike stole my thunder on the public health dashboard, so I didn't have any questions to answer.
He's dreadful like that. He always does that. Absolutely dreadful. I don't know. These deputy law lieutenants, I mean, what they get up to is dreadful. Right. Okay, look, I think we're probably there or thereabouts. David, thank you very much. Victoria, thank you very much. Philippa for coming in as a star with an answer that Mike couldn't answer. So thank you very much for that one. Thank you to all of you. We've got a couple more points to raise. And David, thank you very much for that, and also agreeing to come back with a slightly chunkier, your chunkier version of the report. That would be really, really helpful. And also just a little bit more explanation on the percentages that Dan raised and the reason why it's 77 and not a 10-second 100-mile or whatever it is. So that would be really, really useful. Thank you very, very much for that. Okay. Item 11 is noting the work programme of the joint HOSC. You'll see we've already referenced that earlier on, so hopefully that's familiar. If there are any points or any questions that anyone wants to raise on that, by all means, please put them through to Euron and he will manage those. Item 12, date of the next meeting. This is scheduled to be on Wednesday, the 5th of June, when it will be almost the longest day of the year. And no doubt sunny outside, and we will be baking in this room. So item 13, any other items? Chairman has decided to take it as urgent. You'll be pleased to know there are no other items to be taken as urgent. Therefore, we close the meeting. Thank you very much.
Well done.